And I'll also point out, we have some snacks and lemonade, water for you. So please help yourself to that. The restrooms are out in the hall, right behind this room. And we started to talk about it. It's a heavy topic because anxiety and depression and other health disorders affect so many people. Whether we experience it ourselves, it's in our immediate family, our neighbors and friends. 1 in 6 people suffer from a mental health disorder. And the one that kind of just stops you cold is that there's a suicide every 40 seconds in this country. You know, that is something that should bring people out on a Thursday night to hear more about. So again, I thank you for being here. We are very fortunate tonight to have a real expert, a child and adolescent psychiatrist, Dr. Roger Luhn, and he is our medical director at the Rogers Behavioral Health location in Brown Deer, and he has a wealth of information. We're also going to intercept, no football language here, but a couple of times and have a little table discussion. So you'll see some questions on the orange sheet, and we'll break it up a little bit, but we want it to be interactive and interesting, and hopefully, we do have a lot of material, but hopefully we'll get a chance to let you ask some questions of Dr. Luhn too. So with no further ado, I'm going to hand the mic over, and really appreciate your being here tonight.
Thank you all for being here. Thank you, Anne, for the nice introduction. Thank you to the Whitefish Bay United Methodist Church for hosting this series, because it's a really important topic since mental health affects most of us in some way. This is a huge topic. Depression, anxiety, they're broad, but they are the most common mental illnesses in our country, so they are the ones that we run into the most often in our lives, among our family and friends. Anne mentioned I'm a child adolescent psychiatrist. That means I'm board certified in adult psychiatry and have been also board certified in child adolescent psychiatry. So a lot of how I think is from a developmental perspective, but this talk is focused on primarily how these disorders manifest in adults. My clinical work is in inpatient psychiatric treatment, so that's an acute level of treatment for people who are suffering in some way, in a way that's endangering them. So a lot of people with suicidal ideation or after suicide attempts, and I work with adolescents in that. And then I do anxiety disorders treatment in what we call partial hospital level of care, which is 6 hours a day, and intensive outpatient level of care, which is 3 hours a day, and that's also with adolescents. So we're going to start by talking about depression. Depression comes in several different forms, but most people, when they talk about depression, they're talking about clinical depression. That's how some people refer to it. Clinical depression is usually referring to major depression, so we're going to talk about major depression primarily, but just so you are aware, there are also other depressive disorders. Persistent depressive disorder used to be called dysthymic disorder, which is a longer-term, lower-level depression, so that's at least 2 years worth of symptoms, can be longer, and they tend to be the same symptoms, just fewer of them and less severe. Bipolar depression is the kind of depression that occurs in context of a bipolar disorder. So bipolar disorder is classically manic episodes and depressive episodes in some frequency, so it doesn't have to be one or the other. They can have long periods of euthymia or normal mood. But bipolar depression is somewhat different in how it's approached and treated. Perinatal depression used to be referred to as postpartum blues, or many women experience depression after childbirth. Usually it's transient, goes away in a few weeks, within a couple of months. But when it persists, and it can also occur before delivery, so within pregnancy itself, when it persists, it's very disruptive, of course, to maternal-child bonding and also the care of a child. So that's a kind of depression that is very serious and is, again, treated in many of the same ways, but paid attention to somewhat differently. There's premenstrual dysphoric disorder, so that is, as it sounds, it's a kind of depression that follows this menstrual cycle. It includes many of the symptoms of PMS or premenstrual syndrome, which people are familiar with, but it also includes a mood component that comes and goes during the course of a month. Again, the treatment is somewhat different, but the symptoms are a lot the same. Seasonal affective disorder is a kind of depression that occurs seasonally, so as you might imagine, the incidence is actually higher in northern latitudes. So in Wisconsin, this is more common than Florida. And the reason for that is probably because it has something to do with the light intensity and exposure. And in northern latitudes, we just don't get as much light in the winter. But people can be affected quite severely during winter, early spring, well into May in Wisconsin, with these kind of depressive symptoms. And then atypical depression, actually removed that at one point from this slide set because it's what it sounds like, it's atypical, so it presents somewhat differently and is treated somewhat differently. So the DSM-5 criteria for major depressive disorder. DSM-5 is the Diagnostic and Statistical Manual of the American Psychiatric Association. So it's the manual whereby we diagnose. So you got to have a certain number of symptoms. The important part is it's got to persist for more than 2 weeks. It's got to cause significant impairment or distress. And it has to, one or two of the symptoms must be low mood, sadness, nearly every day, most of the day, or loss of interest and pleasure. So you actually don't have to be sad all the time to have depression. You might just have anhedonia, which is loss of interest or pleasure in activities that you would normally enjoy. The other symptoms include from this list change in appetite or weight, insomnia or hypersomnia, so too much or too little sleep, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness or excessive or inappropriate guilt, difficulty concentrating or making decisions, and recurrent thoughts of death or suicide. So major depression is the biggest risk factor for suicide, actually. But so it's a combination of symptoms. You don't have to have all these symptoms. You have to have a certain number of them, and some people have them all. It's a very common disorder. As you can see, I'm really not going to risk using legs I can. So the prevalence, so in a year period, 7.1% of adults in the United States in 2017 had depression. You can see that the sex distribution is a little skewed toward females, so it's more common in women, less in men. The age distribution is, it's more common in young individuals and decreases in prevalence through the age groups. And then it's more common in whites and American Indians and Alaskan Natives is what that 8.0 is. In adolescence, you see the curve looking somewhat different, and also the prevalence is higher. So this is higher in adolescence, and the skewing is greater. So it's about 3 times as many girls as boys have depression, or of people who have depression in adolescence. It's very much more common in girls. And you can also see, oops, I knew I shouldn't risk using the pointer. So you can see that, it's not that common in early adolescence, so 12 and 13-year-olds. You see this rising incidence as they age. So by 17, 16, 17, the peak incidence occurs, and then if you look back to the last slide, those young adults also have a higher incidence. Whites are overrepresented, but also Hispanics and Asian Americans, the prevalence is a bit higher. So depression is a very serious illness, and it needs to be thought of as an illness. Its burden includes impact on role performance, so marital role dissatisfaction or dissatisfaction. So people they struggle in their marriages when they're depressed. their parenting takes a hit. It's hard to be an effective parent when you're suffering from a disease like depression. Work absenteeism is quite high, and underperformance at work is also high, so that would, days out of work is exceeded only by headaches or migraines, other chronic pain conditions, or cardiovascular disease. So if you think of economic burden, there's a tremendous economic burden in our economy overall, but also in individuals and families due to this disorder. Its impact on health cannot be understated. So people who are depressed have increased incidences of other diseases like coronary artery disease, stroke, diabetes, heart attacks, certain kinds of cancer. It also, if you have an illness and get depressed, it may worsen the course of that illness. So both can be true. Onset earlier in life means several potential outcomes, which can include decreased educational attainment, decreased probability of marriage, increased rate of divorce later in life, increased teen childbearing, increased unemployment and work disability later in life. Yes?
Are those statistics the same since 2011? Have they changed at all?
I don't know exactly, but for my clinical work, it's a bad disease and it affects life throughout. A lot of who we are as adults is impacted by who we were as children and the experiences that we went through. So childhood trauma is a huge risk factor for depression, but depression itself as a disease is a risk factor for later mental health problems like recurrent depression. So depression actually has a pretty high rate of recurrence in individuals, and the rate is higher the earlier it has onset. And with earlier onset, there's a greater risk of other illnesses like bipolar disorder. So the earlier onset of depression, the higher the incidence of it actually being bipolar disorder. Suicide worldwide, so this is just from a WHO report this month. 800,000 people die due to suicide every year. For every suicide, there are many, many more people who attempt suicide. A prior suicide attempt is the single most important risk factor for completed suicide in the general population. It's the second leading cause of death worldwide among 15 to 29-year-olds. 79% of global suicides occur in low and middle income countries. We think of us all the time, but this is a worldwide problem that affects a lot of countries. And if you look at the means of suicide, ingestion of pesticides, hanging, and firearms are among the most common methods of suicide globally. Now, that's not true in the United States, but it tells me that suicide is completed by whatever means is at hand, and the more lethal the means that is at hand, like firearms, the more common completed suicide is. In the United States, suicide is the 8th leading cause of death. More years of life are lost to suicide than to any other single cause except heart disease and cancer. So this, if we think of mortality, this is huge. 30,000 Americans die by suicide every year, and that's more than 10 times as many attempt suicide. Suicide rates are highest in old age, so even though the rates of depression are higher in younger people, old people are very much at risk for suicide, especially when the losses accumulate and they're struggling with depression and they're dealing with other diseases. Most people who die by suicide have a mental health disorder. The majority of those, a substantial minority, are people who suffer from a mood disorder. 8 out of 10 people who are considering suicide give some sort of a warning or clue. They give some sign. And people who talk about suicide, threaten suicide, or call suicide helplines are much more at risk to complete suicide. In Wisconsin, this is from 2014, so looking back at 2007 through 11, there were an average of 724 suicides per year. Those cluster in the northern and western counties. Middle-aged people had the highest rates. Teens were more likely to be seen in ERs or be hospitalized for self-inflicted injuries than were adults. Nearly 4 out of 5 persons who died by suicide were male. So even though females attempt more frequently, males use more lethal means and die more often. Whites had the highest suicide rate than Native Americans. Firearms are the most frequently utilized means of suicide in Wisconsin. and like I mentioned, are used more by males than females. Among suicides in whom toxicology was performed, many of those are positive for alcohol and 19% for opiates. So the combination of alcohol, depression, and firearms is lethal. What causes depression? So we know that depression is caused by a combination of environmental and genetic factors. Depression runs in families, you're more likely and more at risk if there are other people in your, especially in your primary relatives, first-degree relatives that do have depression. That doesn't mean you're destined to get it, but we all go through life with genetic vulnerabilities. So I might have a vulnerability to diabetes based on my family history, but I may never get diabetes based on lifestyle choices or environmental factors that affect me and intersect with those vulnerabilities. So having the gene, and it's not any gene, but having the vulnerability doesn't mean it's manifest, but it does increase risk. So things that might impact the onset of depression or its recurrence would be stressors. So losses, abuse, neglect, conflict, bullying. How people interpret the stressors that happen to them is really important. The ability to cope with stressors as they occur varies among individuals wildly. The presence of another psychiatric disorder, medical illness, or the use of some medications predisposed to the onset of depression. Rumination itself, so that's like the cow with the cud, stewing on problems, that's a risk factor. But this last point there I think is important. Knowing exactly the factors that contributed is not necessary for symptoms to improve. So knowing what happened in your childhood that may have led to a depression doesn't mean it can't be, that doesn't really affect whether it can be treated or not. It can be treated in the here and now. Of course, there are knowing factors that are stressors in your life and wanting to address those stressors or deficits in coping, that's very helpful. But depression can be treated effectively in the here and now without a lot of delving into past issues. So the biology of depression is not, the brain is still a mystery in large part. So this brain isn't, because this guy's cut open, but so the amygdala, the limbic system is a system that's includes, all right. So the amygdala is part of the limbic system. It's activated by emotionally charged memories, and the activity is higher when a person is sad or clinically depressed. So the amygdala is right there. So the thalamus, which is right over here, so these are deep brain structures. This isn't cortex, which is over here. Thalamus relays sensory information from our bodies to our cortex, and then our cortex makes sense of those. So it links sensory information to pleasant or unpleasant feelings or interpretations. The hippocampus, which is sort of there, is part of the limbic system also and has a role in processing long-term memory and recollection. It links memory with emotion. It is actually smaller in some depressed people, and the exposure to stress hormones, which can be higher in stressful conditions, but also depression, may impair the growth of nerve cells in that part of the brain. So from a molecular or a cellular level, so the major theory of depression has to do with how neurons communicate. So over here, so that's the end of an axon. The axon is the long arm of a neuron, and axons go from one neuron and connect, not physically, but by this close proximity with another neuron, which is here. So the signal, which is really basically an electrical signal, comes down the axon. It causes release of neurotransmitters from these little vesicles. Vesicles are sacs, basically. So these sacs fuse the membrane. You get the neurochemical transmitters here, which is this synaptic cleft, so the cleft between the two nerve cells, and those communicate with receptors on the other surface. All of that is not important to know, except that one of the theory that you all probably have heard about is the chemical imbalance. So chemical imbalance is how people refer to what we know about depression, which is that serotonin has something to do with it, basically, and norepinephrine, another neurotransmitter, has something to do with it, and dopamine has something to do with it. A lot of other things impact depression, and we learn more and more about it. But this is the basic theory that underlies pharmacologic treatment for depression currently. So the accepted and evidence-based medical treatments are based on this synaptic cleft. So this is a psychological model of how people become depressed, which we'll come back to, but it's called the trap cycle. So triggers or stressful life events occur. Problem in a relationship, bad grades, struggle at work, divorce, loss of a friendship. That triggers an emotional response, painful feelings, so feeling sad, feeling lonely, embarrassed, neglected, scared of the future. So the trigger triggers the emotional response. Depression influences avoidance patterns, so the behavioral response to that trigger and emotional response is often some sort of avoidance pattern. So you avoid things you enjoy, you use your smartphone, or you just get stuck on video games, you call in sick to school, you don't go to work, you might avoid interactions with your families, you might stay in your bed, isolate. That then influences additional triggers. You might get fired from your job when you were only in trouble before, or you might have further relationship problems because you're really hanging out in your bedroom or on your smartphone all the time, you're not responding to text. That causes escalation of the emotional response, and you just get a circle. So we'll come back to that because that has something to do with a model for treatment. So we'll take a moment for discussion at tables. The questions, I think, are on your table in orange to match the pumpkins that'll soon be in the yard, right?
That's right.
What are the prevailing attitudes and assumptions in your family and network about depression? And did anything you learned from the presentation so far conflict with that understanding of depression? So Anne, how many? 5 minutes?
Well, we did put a time on it just based on what do you guys think? You want to take like 5, 6, 7 minutes and just talk about that for a few minutes? And we just want to make sure we have time for questions and other, getting to the treatment part too, because it's heavy to hear all these facts. So 5, 6 minutes? Okay, let's discuss. Thank you.